All right, I'm very excited to introduce our next speaker, who is Nanette Santoro. She is Professor and E. Stewart Taylor Chair of the Department of Obstetrics and Gynecology at the University of Colorado School of Medicine. Dr. Santoro completed her residency in obstetrics and gynecology at Beth Israel Medical Center in New York City, followed by a fellowship in reproductive endocrinology at Mass General. Dr. Santoro has had continuous NIH funding since 1989, with multiple serial R-level and U-level grant awards, focused on reproductive endocrinology, menopause, and the effects of obesity on reproduction in women. She has authored over 300 peer-reviewed scientific publications and edited 4 books. She has personally mentored over 100 students, residents, fellows, and junior faculty members, many who have gone on to their own academic careers. Please help me in welcoming Dr. Nanette Santoro.
Thank you very much. It's been a pleasure to be here, and I just want to thank Yoel and the conference organizers for really putting together such a fantastic think tank. So I hope to be able to contribute over the next few minutes by talking a little bit about mind over menopause. Dr. Witzman just gave us a great overview of affective disorders. I am really going to focus more on cognition. And I guess I animated my slide. Here are my disclosures, which aren't really relevant to today's topic. So cognitive loss is terrifying for everyone, but even more so for women because there's a larger burden of Alzheimer's disease or dementia in women. 2/3 of the caregivers for people with dementia are women. And most of that care, as we know, is unpaid, so it is therefore very stressful, and often it's care of a loved one who you're watching sink into the netherworld of dementia. About 1/3 of senior citizens will die of Alzheimer's disease or another dementia, which exceeds breast and prostate cancer combined. And if current trends continue, by 2050, the prevalence will more than double. That is my total Debbie Downer slide that I'm going to try to give you a little way out of after this. So we think a lot about this in menopause and in studies of the menopause transition because we, again, as I mentioned yesterday, we've been a little obsessed with estrogen being a major mediator here. And once again, it's let us down a bit in this field. The speed bump that you see on this slide is at the late menopause transition. So as women progress from pre-transition, which really is regular cycling and what we call normal ovarian reserve, really mid-reproductive years worth of ovarian reserve. As ovarian reserve declines, women have 1 menstrual period within the past 3 months. They have some irregularity. They skip a cycle. That is the early transition. About at a median age of 47 with very wide variation, and that's important in the process. When they get to the stage of prolonged amenorrhea, which is the late transition with at least 60 days of amenorrhea, at a median age of 49, that's when symptoms tend to ramp up. And that's pretty much true for all menopausal symptoms, with vasomotor symptoms leading the way, being the most common and the most inconvenient of symptoms that's reported by so many women. But this is also when we see changes in some cognitive markers. So there is some cognitive change that occurs across the transition, and 2/3 of women will support subjective cognitive change. The biggest one is memory, working memory, and I usually tell my patients, if you find yourself in the kitchen wondering why you're there, but your partner is also in the kitchen with you wondering why he is there, if you have a male partner, then it's probably not a major cognitive problem, and it's not menopause related. It's just some of that working memory loss that seems to go for a bit. Attention and language deficits also become more of an issue. Word recall can be a problem. And there seems to be a reduction in executive function, and I'm going to focus a little more on that because I think that's something that's underappreciated. And again, the most vulnerable time period is that late transition when cycles really start spacing apart. And that's when a lot of things become inconvenient in the menopause transition. Symptoms tend to return towards baseline after menopause. They don't go totally back to normal or to what they were before. The degree of subjective change that women experience exceeds what is seen objectively in terms of measurement. So the level of worry that this causes is in excess of what's actually happening. So the reported change matches the performance change, but the subjective sense that this is more catastrophic seems to be present. Most women remain within a normal range at this relatively earlier age, and it does not seem, we cannot currently link what we see in the menopause transition to what's going to happen later in life. That is currently the topic of the SWAN study. And we're actively looking at that in our now 6th iteration of SWAN, because most of our participants are in their 70s and 80s, and we will actually be getting the endpoint of dementia. So these are the things that we see more during the menopause transition. These temporary decrements: cognitive processing speed, verbal encoding, verbal episodic memory. And it has been noted by Gail Greendale in the initial set of SWAN studies that hormone use attenuates these declines. So these lapses in performance are attenuated, but then the women who complete the transition, whether or not they take hormones, kind of wind up in the same place as hormone users. So hormones aren't exerting, once again, a magical effect or a long-term preventive effect, and there have been a number of studies to try to examine that question. And I know she's been evoked before today, but Neil Epperson, the chair of psychiatry in Colorado, has also taken a look at a lot of these issues as well, and I'm going to quote some of her work. But verbal memory does seem to be the thing that's most vulnerable during and immediately after the transition, delayed and immediate recall. And although patients report that this makes it worse, and one would think it was the case, hot flashes, anxiety, depression, stress, and adverse sleep doesn't seem to explain the changes in most studies. So that's a very interesting point, because as I was researching the rest of literature for this talk, I thought for sure we'd find, okay, you disrupt the circadian rhythm, and that's going to cause problems. It doesn't really seem to be an issue unless they are very severe. So in one study by Pauline Magee, if you've got more than almost 20 hot flashes a day, which really puts you in a special category of torment, I think, is associated with worse memory. So there does seem to be a tipping point in terms of executive function. And not being a neuroscientist, and there's a constellation of neurotransmitters in different parts of the brain that are interacting with estradiol, with stress, obviously with genetics. And these things may all come to bear for women who have been keeping it together, but are a little borderline on the ADD scale. So this is just one of several studies showing the effect of lisdexamfetamine for executive function in menopausal women. And again, Dr. Epperson was one of the first people to look at this. She was looking at adult ADD medications in some women, because one of the cognitive areas where women seem to be vulnerable, if they are not strong in this area to begin with, is in executive function. And many patients will come in and say that they're having difficulty feeling organized. They can't quite keep it together. And I am actually struck in my clinical practice at how frequently the next question has a positive answer, which is, do you have any children with disorders on that spectrum? And many times the patient will say, why, yes, I do. Why do you ask? And they probably have a genetic liability they've compensated for their whole life, and now they're noticing that they're having a problem. So the BAD scale is an ADD scale, and what you can see on the left is at baseline and with placebo minus baseline, that there's been some change with the use of desvenlafaxine towards the null, which is an improvement. So working memory, managing affective interference, going from right to left, alertness, concentration, and all of those aspects that I think collectively contribute to what many patients will call sort of brain fog that seems to come along with the menopause transition, may actually get better. So this is one promising area where I think during the menopause transition itself, we can probably do a little bit better. And just to get back to estrogen, I don't know how many of you are Claude Bernard fans, but I am a Claude Bernard fan club member. There actually is a Claude Bernard museum outside of Paris. And And one of his best quotes is, what we know already that often prevents us from learning. So once again, I think we have spent way too much time in this field arguing about whether estrogen or the hormones associated with menopause, if we give them back, are going to make a difference. Because the bulk of the evidence does not favor a major long-term benefit. There are some studies that are cross-sectional, that are not population-based, that look at hormone users and not users, observational studies, that indicate that there may be a benefit for dementia, but clinical trials have uniformly been disappointing. And I think we're just missing something there. So do hormones help? One of the examples of looking at whether hormones made a difference, and in particular trying to address this hypothesis that early intervention with hormones will make a difference, that this is for some reason a critical window, was the KEEP study. So the Kronos early estrogen prevention trial randomized about 700 women. They completed a cognitive battery. I myself was a participant in KEEPS. I can tell you this was a hard cognitive battery. My inner medical student was coming out during this, the cognitive testing. So they really made it as difficult as possible to get participants to do their best to perform and be able to detect any decrement. 220 of the women were on conjugated equine estrogens with micronized progesterone for 12 days out of the month. 211 got transdermal estradiol with micronized progesterone, and 262 on placebo. There was a very detailed battery, mini mental status, verbal learning and memory, auditory, attention and working memory, executive function testing, and a profile of mood scale. And this just, for those of you who are wonks about the exact testing and what it will do, and I know there's some of you in this audience, this is what the testing consisted of. So it really looked at a number of different domains. I can just tell you that it was hard. We had a mean follow-up of almost 3 years, and there was absolutely no treatment-related effect on these cognitive outcomes. We did, however, notice that women treated with conjugated estrogen, as opposed to those treated with transdermal estradiol or placebo, had improved depression and anxiety scores. So similar to what we are doing in SWAN, which is just to observe women longitudinally, KEEPS has a follow-up cognitive study that is now in progress and wrapping up, and Kajal Kantarsi at Mayo is heading that up. So we will actually get a battery on these women now, almost 15, 16 years later, where we may be able to see if there was an effect. So to the extent that this is still an open question, it will either put to rest or provide some support for a critical window in early estrogen. Hypothesis. So just to go back now to the clinical trial data, in case I seem like I'm excessively negative about hormones, the Women's Health Initiative mental status study performed a somewhat easier battery, a modified mini mental state exam that they scored over time. And what you can see here are the years since randomization, so going all the way up to 7 years in the estrogen alone trial, but as you know, the estrogen and progestin trial was ended early. Active drug was associated with worse cognitive performance in both of the arms of the study. It was not statistically significant in the estrogen and progestin trial, so you can see the P of 0.055, but it's sure close. And the conjugated estrogen alone trial was actually statistically significantly worse. In KEEPS, we have seen some changes in white matter intensities that are not favorable for hormone therapy. So I think that hormone therapy will probably not be the answer, but we can wait for the studies to see. So just to summarize, the transition is associated with frequent complaints of cognitive change in women. The subjective change is often worse than the objective change, and I think it's really important to be to understand and to hear the patient's lived experience, because it really can cause a great deal of distress. And for some women, hormone therapy may help with working memory if they really do feel a deficit. But don't forget about women on the ADD spectrum. And if they have ADD spectrum issues, those may improve with stimulants and be aware that menopause may unmask some compensated dysfunction. Finally, although early onset Alzheimer's disease is rare without a family history, patients who report interference with work or functional impairments really do merit a formal evaluation because they can be picked up early, and tragic though it may be. So what does this mean to me, and where do we go from here? One of the biggest markers that we see once we let go, as Claude Bernard has asked us to, of thinking that there's a pill we can take or there's a magic bullet, is really cardiovascular fitness predicts freedom from so many chronic diseases, and it's actually been a remarkable underlying theme for just about everything in this conference. So I am a former East Coaster who moved to Colorado, and you can say I've drank the Kool-Aid, but being part of a fitness culture really does make a difference. And there's nothing like being my age and getting smoked on your way up a mountain by somebody who looks like they're about 20 years older than me, to recognize that staying fit is really a priority. But we also have seen unexpected benefits. So when I showed you that increase in Alzheimer's projecting to double by 2050, well, we can probably bend that curve merely by emphasizing cardiovascular fitness into older age groups. There seem to be differences that are coming out that were not expected, benefits against dementia. Don't rely on magic pills to keep you healthy. Hormones and other psychoactives have limited indications here, so they should only be used when they're clinically indicated. And it's a little unclear whether doing crossword puzzles prevents dementia or you're not demented because you can do the crossword puzzle, but working your brain seems to be making some difference once again in bending that curve. So I think that's all of my comments, and I thank you all for your attention and hope we have not gone too late.